This is Wellness by Designs, and I'm your host, Andrew Whitfield Cook. Joining us today is my good friend, Sarah Franklin. She's an oncology specialised registered nurse, a naturopath, and an academic mentor. Today, we're talking about something a little bit different though. Although she specialises in oncology, we're going to be talking about nutrition and digestion in palliative care. Welcome to Wellness by Design, Sarah. How are you?
Good, thanks, Andrew. Thanks for having me on board. And
My absolute
looking
pleasure.
forward to talking about this topic. It's a topic I'm passionate about, and I think we could do a lot more work to help patients with digestion that have chronic diseases or end-stage palliative conditions.
Well, we certainly have an ageing population. We're all going to get there at some stage. So I think, first of all, we need a bit of a definition. What does palliative care involve? When is it put into place, and with what conditions?
Well, palliative care is basically to just support someone in the end stages of their life. So I think a lot of people hear palliative care and they think assisting somebody in dying, which is not quite it's a part of that role of the palliative care teams to assist them with that process. But palliative care is basically supporting a patient socially, mentally, physically through that end stage of life. So it's not just that final dying process. So, and I think, again, when people think palliative care, they think of cancer. So they focus in on cancer because they're used to, a patient had cancer and went to palliative care or a palliative care unit. But palliative care extends to people with kidney failure, liver failure, congestive heart failure, your neurological conditions like MS, Huntington's, Parkinson's, dementia. So all of those conditions are a life-ending condition that will require palliative care at some point.
Yeah.
And the conditions can vary a lot. So from condition to condition. So, people with end-stage liver failure will have a lot of bloating and ascites. People with dementia will struggle with cognitively being able to eat or all those things. And I think the other complex thing with these palliative patients is, they're still on a lot of medications to try to support their quality of life. So they're still on a lot of medications, which then have an impact on nutrition, on their digestion. Although those medications might not be life extending, they're there to try to provide further quality of life. So, for example, with congestive heart failure, they might still be on medications for fluid retention to help reduce the fluid load on the heart as a measure to improve their quality of life, but it's not going to extend greatly that. But
No.
In coming with that, you have these nutritional issues that you come across with these medications where they strip you of particular minerals, or we have particular medication interactions. So, and that's where today, I guess, we're looking at, there's a few products here that we can use to help patients in that end stage because we have complexities when it comes to digestion and swallowing and all those sort of things.
Okay, so is there, I know this is a piece of string question, but is there an expected life expectancy where they move people over into palliative care, like, for instance, 12 months, 24 months?
No, not really. It just depends on how the patient's deteriorating. So you can normally tell when the patient's deteriorating, and that's, for some diseases, that's a very slow process, and for others, that's quite rapid. But normally when you start to see, increased pain, a lesser level of consciousness, because these diseases affect their ability to think through calcium or different things. So, progressive cerebral changes where they can't cognitively look after themselves anymore. Obviously, with pathology, you'll start to see the kidney function, the liver function, in some cases, the bone marrow is starting to fail, where you'll start to see changes in bone marrow production as far as from a hematology point of view. So no, there's no piece of string, because a patient with pancreatic cancer might be in palliative care within 3 months. A patient with Alzheimer's could have it for 10 years. So, and some of these diseases are very slow. Generally, as a clinician, we're often treating these patients for a period of time before they reach that palliative phase. I think the problem is that naturopaths are not good, or nutritionists are not good enough at spotting when that change occurs in the patient's care, management of care. So you'll know, because you'll start to see changes in medication rapidly, or you'll start to see the patient come in and say that, you know, they're talking about referring me to the palliative care team. So that should be your first sign that, okay, they're now withdrawing treatment. And then what tends to happen is their medical team becomes smaller. So normally, you know, if you looked at a cancer patient, they've got an oncologist, they've got radiation oncologists, they've got their GPs, they're having blood tests and scans. And then all of a sudden it's like, oh, okay, I don't need to go. I've been discharged from the oncologist. And they can have a sense of abandonment, which isn't true. They haven't abandoned them. It's just that they can't provide any more treatment for you anymore. So generally they then get moved on to either back to the GP or back to the palliative care team. And that's often when a patient will come to you and want you to perform a miracle, which you won't be able to do. And that's where you need to have that integrity around having an honest conversation with your client about not offering hope when there's not hope there. It's more, I'm here for you, I'm here to support you, I'll follow you through this journey or process. And then looking at what you can do to help support them in a palliative way, which might be pain, it might be digestive, it might be sleep, it might be anxiety, that all these things, there's lots of stuff that we can provide for these patients, but it's being able to spot it early enough. Otherwise, what happens is you just end up they think there's nothing more you can do for them, so they stop seeing you. And then all of a sudden you're like 3 months or 6 months down the track going, I wonder what happened to so-and-so, when there wasn't a part there where you could have kept treating them and you could have improved their quality of life, and you could have supported their carers and the people around them to have an active role to support this person emotionally and physically through this process.
Part of what you spoke about before about the medical team shrinking because there's nothing more they can offer them, I do believe that part of that issue has got to do with communication. I was reading a story on Australian Doctor recently, and it was saying, now forgive me, I think this was, I'm going to get this wrong, but regional Queensland, and there was some huge amount of patients who were discharged from hospital without discharge planning, without effective communication to other healthcare practitioners, whoever they may be. So it is an issue. You know, who do you blame? You know, everybody's overworked, everybody's under extreme pressure, there's not enough staff. I get it. The fact of the matter is the patient's in the centre of this, and they need care. So should it be part of our care to maybe take the baton and say, I'm not going to wait for this to happen. I'm going to say, hey, guys, I noticed, you know, Mr. Oncologist, Mrs. GP, whatever. I've noticed that patient X has, been discharged. I, haven't received any communication, or here's some communication to you. I'd like to be part of this healthcare team, blah, blah, blah. Is that part of what you do? Like, you're used to this as an RN working in the hospital system, but working outside of that, do you communicate with these doctors and other healthcare professionals at all?
Yeah, I mean, I'm lucky enough in that I've got relationships with the medical team because I've come from that industry, so I've got relationships there. But do I think as a naturopath or nutritionist you have a responsibility to support that patient? Absolutely. So, and I think if you don't, you're not doing your job that you should be. So I think the buck does stop with everybody. I think if you're a part of that healthcare team, if you feel like the patient doesn't have the support services, and if they don't have those things there, then I think you do have a responsibility to know who those services are and how to refer them, who they are, and how to make it happen. You don't need to be a doctor to go. Maybe you need to get back to your GP and discuss a referral to a palliative care team or community services so that you don't have that carer burnout. So I think that's a part of your role as a clinician, to know when to refer, who to refer, and how to refer. And I think, you brought up the rural thing before. Absolutely. There's complexities in both. I think in the urban environment, it's complex. It's a far more complex system to navigate. People are busy. People, support structure don't have time and finances to look after each other. Often they're more isolated in an urban environment. One of the advantages of remote is that those guys tend to stick together and they have a better support structure around them and around the town. They tend to look after each other in a rural setting better than an urban setting. So urban settings have more services, but it's a more complex system to navigate, where rural have less services, but they've got these benefits of a sense of community and a better social, generally a better social support, because they're used to probably having a lack of services, that they've learned how to navigate that better. Whereas in an urban environment where we've got that expectation that we can just present to an ED that's going to have a specialist available, which they don't.
Let's face it, they're just tougher.
Yeah.
It's just tougher.
And respect to the rural, shout out to the rural naturopaths and nutritionists, because they do a lot of heavy lifting out there, because they really do bridge the gap between, there's some huge gaps out there, and they really do bridge those gaps out there. So rural naturopaths and naturopaths and nutritionists really do a lot more heavy lifting. They're counsellors, they play a much more physical role in, checking blood pressure and everything. So they definitely do, and they're a part of the community. So it's harder for boundary setting, all those sorts of things. So, huge respect for guys that work in those rural communities with the services that they've got.
What are the issues with the activities of daily living that you see and you treat? You've mentioned pain, you've spoken about swallowing. Can we delve into these a little bit more?
Yeah, so often what you start to see is, with some of the neurological conditions, etc., you definitely get those digestive issues. So, you might have a patient with throat cancer, or you might have a patient with, throat cancer or radiation. You might have a patient with stroke, that can't swallow effectively. You might have a patient with dementia or Alzheimer's that doesn't know how to swallow cognitively. So I think when you're looking at these palliative care, aged care, and that's why I guess I'm grouping them a little bit, because we tend to, in geriatric care, see a lot of the same conditions as palliative care, because we tend to see more palliative conditions in the aging community. So the main things we sort of see is like oral health. So a lot of these older people, or, depending on what's going on, they might have dentures, or they haven't got dentures, or they're not able to chew their food properly. So you've got oral issues, you've got digestive issues where you've got, strictures or narrowing of the esophagus. So they're an increased choking risk. So then you're needing to use thickened or grade, you'll have speech pathologists involved to review what you can use. You've got poor appetite because they're not moving as much. They're more sedentary. They're losing muscle mass. So their metabolism slowing down. So they're often not hungry. They're often dehydrated. They're often nutrient deficient. They tend to want to eat foods that are crap, that are high calorie, but, low nutritional content value. So there's a lot more education around what type of foods would be beneficial. And then if they are in an aged care facility, or if they're in a palliative care unit, then it's the obstacle for us is how do we communicate that so that can be implemented in an environment that you're not in control of, because it's all governed by, those institutions. So then how can you communicate to the charge nurses or the family or the doctor so that you can implement nutritional changes or implement supplementation that's safe, because you're not going to be able to get anything through without the family or the doctor basically ticking off at it on the end. So that comes around communication.
So with regards to things, I mean, you could start with appetite and oral health indeed. So we've got anywhere from, as you say, dentures, you get atrophy of the jaw.
Yeah.
So the dentures that once used to fit well now don't. They can cause ulceration, pain, lack of chewing. There's a whole
Yeah.
sequelae that comes from that. You've got the changes in just the appetite, and as you say, they tend to crave the sweet things, the sweet sensation. The sense of taste of sweet comes
Yeah.
back in, if you like.
Yeah.
So they like their desserts. But this is at a time when they're very often suffering from sarcopenia. So you really need to look at
Yeah.
protein. So
Yeah.
these are real big issues. There's defecation, lack of control
Yeah.
of defecation,
Yeah.
incontinence, urinary and fecal.
Yeah.
You mentioned before about as they get older, as these patients get older, they've got a lack of mobility. So you haven't just got things like bone mineralization, things like that. You've got to say, okay, well, what happens to that calcium? Because it goes out. So have you got a kidney problem? Have you got
Yeah.
bed sores? Have you got vitamin D, lack of vitamin D?
Yeah.
There's so
Yeah.
many rabbit holes. Your mind busts me like Swiss cheese, Sarah.
Luckily, I love it. And I love, as much as it's an area that people go, oh, that's really odd that you're passionate about that, but you really can make an impact on these guys, and you can really improve their quality of health, and you can really help the family to feel supported, because they often feel lost and they don't know if what they're doing is right or wrong. So just having someone to help them run alongside them, to give them a purpose and to keep that connection. It's complex. There's role changes. There's, partners becoming parents. There's, you've got so many social issues. You've got kids that are, you might be navigating a palliative care with a child that's involved. So you might be navigating, how does a child process a parent passing away, or getting them prepared and ready for what they need to do, or, how can you keep the child involved with the palliative care? Can you give them a little task that they could do with the parent to keep a connection there that is purposeful, but at the same point appropriate for that child, depending on their personality and their age development of how you can sort of, because often you don't want to just exclude them out of the picture, but it needs to be done in a way that's appropriate for that child.
That's very thoughtful of you. I never, ever would have thought of that. Absolutely brilliant. Can we go through, Sarah, what this instigation of your care with palliative care looks like? Like, what sort of things do you actually say with regards to, let's say, poor nutrition, multivitamin or vitamin D, when they've got, say, a swallowing risk? A swallowing issue.
So if there's a swallowing issue, normally they'd be referred to by normally you'll have a speech therapist involved, and the speech therapist role is to assess their swallowing, to make sure that, because there's a risk as they start to lose that swallowing effect, or you can't chew your food properly, there's a risk that you'll choke on your food and then you'll aspirate and the food will go into the lung and then you'll have pneumonia. So that's our biggest risk, is aspiration. So generally, if the patient's coming in, or the family, and saying, oh, that we're noticing when they're drinking, they're coughing, or when they're eating food, they're coughing a lot, it's usually because they're choking. So then you go, well, again, your responsibility is to go, you need to go back to your GP, because we probably need a speech therapy review to check the gag reflex, which the GPs or specialists will refer off to. And then what happens is a speech therapist will come back and give you a grading. They'll give you a thickening grading, because they'll be able to assess the swallowing to show you what's important. So I guess that's where, with supplementation, you might go, well, if you're trying to increase their absorption of their food and their tummy's not very well and they're nauseous and they're bloated, so what liquids could you use, or what powders or liposomal forms could you use? Because these people are going to be deficient in B12 folate. They're probably not eating any green leafy stuff. They're not eating enough protein. They're probably vitamin D deficient because they're sitting inside all day. And there's some medications that decrease vitamin D as well as B12 folate. They're probably magnesium deficient, which would then increase cardiac risk. So what powders could you use, or liposomal or liquids could you use? Because you're going to have to mix it in whatever that swallowing, whatever you've been approved for. So, but it's also, if the patient is describing those issues swallowing water, water's normally the main one that you see. So you'll often go, you'll see them drinking water and then they'll start coughing. That's usually a sign that it's too thin, and the muscle reflex is just it's not fast enough to register with the brain, and they're choking on the water. So, and that's where you've got to think outside the box and go, okay, we've got a nutrient deficient person. They're not going to be able to tolerate a lot of supplements. So what can I do in a powder or a liquid or liposomal form that's going to be able to have an impact, but be able to tolerate? Because tablets will usually become something that you can't use, or tablets or capsules at this point, or if it is a capsule, can you open it up and use it?
Yeah. Do you tend to look for, let's say, for instance, there's some great tasting protein powders nowadays, whey protein with a good nutrient profile. Do you tend to sort of look at that? I guess, naturopathically, we tend to like to avoid dairy products, but in some sense, I'm not that scared of whey. I actually like it.
Yeah, and I think you just got to be a bit realistic at the end stage. You're not, we've got to be totally on point with nutrition and sugar. So, yeah, absolutely. There's some really good, nice protein powders out there. If you're younger and you're healthier, you can be a bit more, this is what I want you to eat, and let's be stricter around sugars and processed stuff. Like, obviously, we'd all prefer patients to use less processed stuff because we know that it's not good for you and the risks associated. But when you're a palliative patient, it's like being, I don't want to take morphine because I'll get addicted. It's like, well, that's the least of your issues, being addicted to morphine. So it's the same thing with the sugar. I think you've got to be realistic that sticking to your guns on some of this stuff isn't going to work. So, but absolutely, could you try chia puddings with protein powder, or could you do smoothies with vegetables and juices and then somehow blend them into, basically like children, where can you make them into little ice blocks and stuff? Or, you've got to probably be prepared to, could you do a jelly with some gelatin, some collagen powder, and make like a little jelly or something where you can make some fruit juices or blend something up and put a bit of collagen powder to thicken it up. And, you do these little things along the way to help build their nutrition, but in a way that's healthy, but it's also being realistic about, that you're there to help their quality of life at this point. You're not there to extend it.
Sarah, moving on from swallowing, when we're talking about mobility, muscle mass, institutionalization, a lack of appetite, do you tend, and indeed the swallowing issues as well, do you tend to utilize, maybe a whey protein concentrate or something with a good nutrient profile? What do you tend to favor?
I think, when you're at this point, or at that palliative point, it really comes down to texture and it comes down to taste. So they're not going to be hungry. They're not really going to want to do anything. They're going to be depressed to a degree. So, you also got the challenges of someone who's really struggling at the moment. So asking them to take a really yucky powdered drink is not going to go well. So, so to be honest, at this point, yes, do I look for something? But basically, we almost move into that, I guess, it sounds terrible, but you just start really looking at how much protein, how many calories, how much carbs have you got in it, how much fat's in it. So you really start breaking down to what nutrition is in there. So, and what vitamins and minerals are in there. So has it got enough of what we want? So definitely I look at whey protein. But I also look at, yes, it's nice to use, rice-based or soy-based or different pea proteins, whatever. But generally your whey proteins are the better tolerated on taste. So if a patient prefers to have a whey protein with banana in there and honey, and you might be able to put some other things in there to help build it up, your collagen, you could put liquid iron in there, you could put, B vitamins, whatever. You could put different things, magnesium. So you can put little bits in there. Obviously, you've got to do it around taste, but so that's where I'd be going. To be honest, it's really, I'm looking at the nutritional panel and I'm trying to, it's almost I'm going to use a protein powder that I would use for a bodybuilder who wants to gain muscle mass. So I'm going to be using something that's as strong as what's the most I can get in the smallest amount of volume, because they're not going to be able to tolerate much. So that's where, again, you're looking at your protein powders. There are other formulas on the market that are high calorie, what we call very high calorie, dense liquids that we obviously use in the hospital sector, and that's what we use with tubes, NG tubes. And some of these patients might even have a nasogastric tube or a PEG feed in their stomach. And sometimes even these things, as long as you okay it with the doctors, they're happy. As long as you're blending it down properly, you can use these things, particularly through PEGs, that you can sort of supplement through the PEG feed with your liposomals and your magnesiums and your bits and pieces. So you can, if they are eating through another mean other than through their mouth, again, that's something that you can discuss with your medical team to go, well, if we make it up and if the family are comfortable to do it and it's all dissolved and it's all broken down and it's all soft and there's no risk of it blocking the tube, then is that something that we could sort of look at? Or the same with your liposomal products, your liposomal different nutritions that you can get with magnesium or your other, there's lots of liposomals available, is, they would be fine to put down an NG tube or like a thinner tube because you're using such a low volume, that's something that you could do as well. So there's lots of ways if you can think outside the box. But again, all of these things need to be done around communication and discussion, and that everybody's happy with what you're doing, because generally these patients are going to be in an acute setting, and if they're not in an acute setting, they're at home and they're being managed by palliative care nurses. So then it's communicating with our palliative care team to go, are the nurses happy with what we're doing? Because you don't want to be doing something that creates an issue because you didn't know. And then the medical team are a bit perplexed as to something's changed or something's deteriorated or something's gone wrong. And it's like, so if everyone knows what each other's doing, then everyone can work around that. And I think naturopaths are starting to build a better role in that allied health sector. So I think we've been the poorer, the very poor sibling in the healthcare sector. But we're now seeing a lot more naturopaths and nutritionists in GP clinics and playing a bit more of a role. So, and I think through the formal education system that we're under, where now it is about a 4-year bachelor degree or they've got master's degrees, that I think that they're starting to take us more seriously. So I think in time, it's only going to, our role in that is going to increase, where we'll continue to work with dietitians and nutritionists or, whatever that may be, speech therapists, to have input on, because, our view is so holistic in their care. It's not just, like a dietitian that might be more focused on the macronutrients, or we're not focused on one little bit. We're focused the beauty of what we do is we're so holistic in our approach that we can really pull together lots of different allies that they're using, psychologists and speechies and OTs, and there's so many allies that we can communicate with to bring together. If you can see a deficit, that we can really play that role.
True
to have
holistic
more time
care.
in the GPs. Yeah.
Okay, so earlier on you mentioned medication issues. Let's go through these. What's the typical sort of thing that you see? I think we mentioned, swallowing a tablet earlier, but obviously there's other medication issues with, leaky blood-brain barriers as we age, and toxicity if your liver isn't functioning correctly or your kidneys aren't functioning correctly with regards to biotransformation of medications. Tell us what you see in your clinic with regards to this.
Probably the main things I see are either, definitely like potassium, magnesium. Like I definitely see a lot of magnesium deficiency because of chemotherapy, because I see a lot of oncology patients. So there's certainly a lot of medications that drop your magnesium down. You also see that the magnesium drop in a lot of autoimmune, like some of your rheumatoids and those guys, because of the medications that they're using, can drop magnesium. Calcium is another one, and obviously when your magnesium calcium goes out, then you can, from a nursing perspective, you can end up with some pretty serious medical emergencies in regards to the heart that happen quite quickly. Your potassium with your, some of the medications that you're using for fluid. So your congestive heart failure patients and those guys, or some of your livers might be on medications that affect the potassium levels. So do you need to then be increasing, potassium? And yes, there are medications to increase all these things, but there's also foods, and yes, you can supplement, but you can try and increase potassium through diet as well. Vitamin D is a big one that we see, just because a lot more people are spending a lot more time inside, and we're now understanding the key role that vitamin D plays as genetically, how integral it is in how we synthesize things and how things work. The same with your B vitamins, your methylation pathways, and if you've got a genetic variant on that how much, I wouldn't say I'm obsessed with methylation, MTHFR, but I certainly acknowledge that it plays a big role. So if you do have that, then that's something you definitely need to consider as well. So, because people are definitely not eating enough green leafy stuff. I think protein is definitely a big one that you'll see on their pathology. When you're reading the pathology, you'll see that continual drop in protein. And then once you get that down, then you have a whole catabolic effect in the body, where once it starts digesting itself, you have all sorts of troubles with the kidney and the liver at that point, because it's doing something it shouldn't be doing. And then obviously nutritionally, if you don't have enough iron, if you don't have enough B12, if you don't have enough folate, if you don't have those essential nutrients, the bone marrow can't produce white cells and red blood cells, and the bone marrow can't do its job. So that's when you'll see that in their pathology, you'll start to see that the hemoglobin and the white cell count and the platelet counts. And then when you start to see them all out of whack, you then know that it's probably an upstream issue, that it's not that they're being damaged in the blood, they're not being produced in the first place. So Again, the kidneys can affect the bone marrow. So the kidneys talk to the bone marrow on how to produce these things. So then if you've got a patient with kidney disease, you're going to see changes in hematology because of the way that they all talk together. Or the same with the liver. Once the liver starts to fail, then can it actually metabolize the medications? A lot of cardiac medications that we use for congestive heart failure impact on the kidney and liver. So, I know in the nursing world it's a common debate between the cardiologist and the renal specialist on, that finding that fine balance between the heart and the kidneys, because they definitely have impacts on each other, and trying to get that balance right is very difficult. But any patient with any of these COPD, any of the neurologicals, your neurological patients are going to be magnesium deficient, zinc for everyone. Magnesium is a big one for the nervous system, for that myelin sheath. And I guess with your brain, it's, when you've got some of these inflammatory brain conditions, what actually does cross the blood barrier or not, and understanding that, and how can you support that neural inflammation when there's chronic disease as well.
Can I ask about, when we're dealing with palliative care, we're talking about moving towards the end of life. So with regards to that, do you have hurdles, resistance by the healthcare team, even the family, to say, what's the point? How far do we go with this sort of thing? How much money do we throw at this? Do you ever have that sort of, or have to have an uncomfortable conversation about, listen, this is worthwhile, but this actually, you're not going to get much bang for buck from it. We can give it to you, sure, but it's not going to change. It's not going to have a great impact on their activities, their daily activities of living.
Yeah, I think there's probably two answers to that question. One is definitely yes. So if there's products that we're using that aren't of benefit, why would we use them? We're just increasing load, we're wasting money, and what they're going to be able to tolerate is going to be minimal. So you've really got to condense what you're doing. So absolutely, do you need to scale back? Anything that is not going to improve their quality of life needs to go. So definitely yes. The other part of your question is, have I ever had to have discussions around patients feeling like it's not a benefit? Never. Because generally, It's more the other way, that it is such a under-assessed, undervalued part of what we do, that, to be honest with you, I'd say 90% of naturopaths and nutritionists don't take an active role in palliative care. So,
Wow.
and that's purely because they didn't know that they could. And that's probably because the practitioner didn't let them know that they could. So, to be honest with you, I've never had anyone go, what's the point of seeing you in palliative care? They're all like, yeah, what can I do to help this person through this last stage?
Okay, so is this then, do I be brazen and say the word failing? Is this a failing of naturopathic teaching institutions, in that they're not teaching it as an important part of naturopathic care, and therefore people don't know,
Yeah, I do.
That's why you're an academic mentor.
I do. So, as a palliative, oncology nurse, and a nurse that's done palliative care and worked in palliative units, being a part of someone's death is like being a part of a pregnancy or birth. It can be a really beautiful thing that you can make really beautiful, and everyone can be supported and valued. But often that's not the case. And I think that is a failing on our education and awareness, in that people don't know when to recognise it. They don't know how to have the hard discussions and to have that communication. And I think at the end of the day, you have to be comfortable with your own immortality and belief systems around that to be comfortable to work with death. So I think you need to be, you really need to be comfortable where you are. What do you think about your own immortality? And I know that, I know for me, I struggled with it initially working in palliative care as a nurse. It took me a long time to be comfortable with death. And fortunately, I had colleagues that were able to, I had that support structure around me to help me process that. And I guess when I became a naturopath and I had kids, I had a lot of anxiety around working with people dying again, because you're like, oh my God, everyone I see is dying, and you get a distorted perception on reality. And then for me, I had to really sit there and go, what was that about for me? Where was that anxiety coming from for me? And for me, it was purely ego, that I thought that if I died, my children wouldn't be okay, which was not true. So for me, that's once I was able to nail it down and go, actually, my kids would be okay. That's my own ego, that I think I'm so self-important that they wouldn't thrive. When, yes, of course, I know that they would be upset, and of course that would have an impact on them. But I also know that they would have been okay. And there's lots of kids that have lost a parent that thrive and they grow from it, and it's not the end of the world. So once I was sort of able to move through that and acknowledge that, then I was, and again, to be comfortable with my own immortality, that once you surrender to that, you can be quite comfortable and have open discussions around all those fears that those patients have, which is, what's going to happen when I die? Is it going to be painful, and what's going to happen? So, and a part of that is understanding the dying process and these different diseases. So if a liver patient said to me, what's going to happen? I'd say, well, you're probably going to get ascites, and you'll get a build-up of fluid in your tummy, and they'll try to keep that down as much as they can, but then it will press on the lungs, and you'll get shortness of breath, and you might get more confusion. So and they all have a different process; they're not all the same. So the way that a liver patient dies is different to a way a person with chronic kidney disease dies, where they loss of appetite, increased confusion, drowsiness. They're all different because their pathology is different. So I think that's, again, understanding, if you have a palliative patient, do some research on what the pathology is like at the end, because how you would treat them, and preparing the patient and the family for when these things come on. I remember reading they did a coroner study, and they were talking about just that preparation of when people were identifying deceased people for coroner's reasonings. And they had one study where they really explained to them what's going to happen. So you're going to come in the room. This is what it's going to feel like. It's going to be cold. This is what's going to happen. We're going to come in. The person will be, they talk through the whole process before the patient, the family member went in the room to identify the body. And then they had a group where they didn't so much, and it was huge. It was huge, the the difference when people are prepared for something and they know what's coming and what that experience is going to be like, it's not so scary and it's not so, they're ready for it versus going, oh my God, what's happening? This is all out of control. And the family become distressed. And is that normal? And, you know, they're not prepared for it. And, you know, it's not just a failing on our industry. It's a failing on the healthcare sector, how many palliative patients are not managed well, and then they end up at home, and then it ends up becoming a disaster, and ends up being a really traumatic thing for the family.
Yeah.
Rather than preempting it and going, okay, we need to put these things in place so that we're ready for this.
Sarah, I'm going to put up in the show.
Sorry.
But you know, but you know what? It shows your care. You had me teary there for a tick, but I'll get over it. One of the interesting things I'm going to put up in the show notes is it was a podcast that was on ABC Conversations. This one was done by a woman, led by a woman, but she was speaking with an oncologist who openly discusses death very early and talks about that very early in the meetings with her patient to say, what would you like to happen if and when this should eventuate? And it's a beautiful podcast. So we'll put that up in the show notes, and I'm blinking. So Sarah, I can't thank you enough for taking us through what you do every day. But when I see you doing it, I am just inspired. I am awe-inspired by your care. Oh, damn it, of your human,
sorry, Andrew.
not just your patients.
If I could give you a virtual hug, I
would. Well, you're only 3 k's away, but I am truly honoured to know you, because you are a caring individual who really is there for your patients, and I thank you so much for sharing your expertise and that care indeed with us today.
You're welcome.
And thank you, everyone, for joining us. Sorry, teary moment. I'm a bit of a sook. But we'll put up as much information as we can in the show notes. Obviously, you can find all the other podcasts on the Designs for Health website. I'm Andrew Whitfield Cook. This is Wellness by Designs.